Welcome, everybody. Happy New Year. Starting 2023 out with another roundtable on training, and I'm super excited about this one. Just as a reminder, as always, it's a discussion and not a seminar, so we really encourage you to pipe in with questions and comments, suggestions. This is just a big discussion, so please do participate. You can turn your video on or off and your audio on and off. If you forget to turn it off and things get loud, we may mute you. We are recording and we may use these videos, but a lot of times we post them on YouTube so other individuals can access them. So just know that it's being recorded for future use. But also, these opinions are our own and do not necessarily represent the views of any of the Missouri Psychological Association. This is a Category B credit, so make sure you've signed in with your full name. And we will send out a PDF attachment within a business day. And if you're not a MOPA member and you'd like documentation, please contact Emily at support@mopaonline.org. I am very happy today to hand this over to Dr. Lute and Micah Gillen, both individuals that I work closely with, and very just happy to have them in my career circle in any capacity. So we're going to talk a little bit about some of the trainings that they have put together and training in general. So I'll hand it over to you, Dr. Lute, if you want to introduce yourself and take it away.
Thank you, Dr. Gillum. Also glad to be here. Glad to see so many of you, especially given that this is a short week and a quick Thursday. It happened a little bit fast. I do want to apologize for the fact that I'm in your face. My camera is having difficulties making much adjustment today, so I'm probably pretty much closer than is comfortable for everyone's personal space. So please bear with technology as always. So just real quickly, for those of you that don't know, I've served in multiple roles that relate to this topic in particular, including working as a director of training in an integrated program, working as a BHC, working as a supervisor with multiple students, different degrees, different levels, etc. So I think between Micah and myself, we're going to aim to talk about both training and supervision, which to some extent may sound like they're synonyms, but it depends on sort of maybe where in the process a person is, so to speak. So we're in their own training path. So as Dr. Gillum said, these are always so much more meaningful when we hear from you as well, because certainly the opinions that are expressed are ours. We do try to obviously back them in data and research, and we are not subject matter experts in every single thing. So hearing from you can help all of us grow together. So that's my little spiel for right now, and I'd like to introduce my co-facilitator, Micah.
Hi, everybody. I'm Micah Gillen. I have been doing BHC work for the last 2.5 years and recently changed positions to a coordinator of primary care behavioral health here at Burrell. And still doing BHC work alongside that. So I'm excited to talk today about training, talk a little bit about what we did here at Burrell, what we created, and hopefully get some feedback and some questions and discussions so that we can all learn from each other today. I wanted to start out by talking about, what really drove me when I was asked to create a training program was to look at the why, the big why behind everything else. There's a book that I read called Start With Why by Simon Sinek. And if you haven't read that, highly encourage you to. It's a really great book, but it talks about how we can know the what, we can know the how, but really what we need to do is start with why. And so as we're creating a training program, as I was helping out with creating one, I was really focused on the why behind our work. And one of the things that Rob and I had talked about when we were talking about this was the quad aim Used to be the triple aim, but the quad aim. If you're not familiar with that, it's improved provider satisfaction, lower costs, better health outcomes, and better patient experience. And we have research to show that BHC work and having a behavioral health consultant in a clinic does all of those things and does it really well. And so when I was creating this, I really wanted to make sure that was at the forefront, that we were focusing on all four of those things. We weren't just focusing on people being able to assess for behavioral health concerns, but to be concerned with the big picture, with the why. And one of those things.
Mind if I add something real quickly?
Yeah, go for it. Go for it.
I appreciate your mention of the quadruple aim. As we know from the IHI, that, as Micah said, that is absolutely essential to support and back and help us sell, the services, because we know that they work all for multiple parts of a healthcare organization, as well as patient experience and care. I think the other why that I would add to that, that's not quite in the quadruple aim, so to speak, is that we all likely know at this point that the need for behavioral health, or the demand for this integration, because it is so successful, is much higher than the amount of trained behavioral health providers. So even with so many students heading into the direction of primary care, there's only about 11%, last time I looked, of doctoral level programs or master's level programs that actually provide any introduction to integrated care. And most often those are housed in like medical institutions or academic institutions that are that already have multiple student bodies where they can provide that easy integration. So sometimes we're retraining to some extent, and you can teach an old dog new tricks, for lack of a better phrase. So I just wanted to kind of throw that in there, Micah. I hope I didn't get you off track.
No, I appreciate that, because that's one of the things that we've run into that was a little bit hard at first, was if somebody didn't have experience in PCBH, this was a new thing, because a lot of people, I think myself included, when I came in, I shadowed somebody at their position for a while, and still didn't really have a clear understanding of what goes into being a BHC. And it wasn't, and I quickly realized that it wasn't just, oh, I need to assess for anxiety and depression, but it was this whole holistic care when it came to different medical presentations. And so yeah, I really appreciate that point, because that's one of the things that if we aren't clear on that why behind our training, then it can get really confusing and really muddy. And we might find that as we're watching people in their progression, they aren't where we expected, if we don't really clearly explain that why. One of the things that was really important to me too in creating the training was to create something that really focused on enhancing clinic culture. And so one of the things that I would encourage you to do too, if you are creating a training program, would be to figure out not just the broad why, but the why for your program too, because that might be slightly different than somebody else's program. And so for me, it was really important that we engaged in clinic culture. Like we were part of it. We didn't feel like we were outside of it, and that we were actively working to change it for the better. So
which, along those
yeah.
lines, Micah, I think it that really underscores I don't necessarily want to even call them soft skills per se, but for most of us as mental health professionals, our knowledge and understanding of systems, family systems, as well as just general group systems and processes, it far extends just individual one-on-one interventions in terms of our ability to, as Micah used the phrase, impact the clinic culture, again, referring to the quadruple aim. Like, if we are making our PCP's days go more smoothly, right? Just systemically, people are happier. There's less grumpiness. Patients don't feel as rushed, just whatever ways we can look to work on like pathways, and how do we help things go more smoothly, or how do we build team culture if that's not functioning well, or it can be improved upon, because I don't know the numbers, some of you here probably do, but to recruit and retain, let's say, a medical professional, and I'll add for me, since I'm in a rural environment right now, it's an exorbitant cost to go through that process. And so if we can retain ourselves, each other, a team, we're doing something great for the system and reducing costs overall, which ultimately then don't trickle down onto patients as well.
Yeah, I totally agree. 100%. And one of the things that was really important to me when I first started was, hey, I did some silly things, even like I would be there for a listening ear and that kind of thing for people, but then started celebrating birthdays and pointing out things that like we weren't doing. We weren't celebrating people for being people. And that's something that, as behavioral health consultants, sometimes we come in and go, that's not my job, but it really is, because that's impacting the clinic culture. And what we found was, when we did that, the culture changed, and people stayed, and we even had a employee leave and come back for this job environment. So it's so important that when we are training clinicians to be BHCs, because it's different than just being a clinician, we have to explain that really well, that's part of the job, part of the mission, part of the why in what we do as BHCs. So I wanted to talk a little bit about what I did, and hopefully I can share my screen so I can show you a little bit of what we created here. But there's a few different components that seemed to be really helpful for us when we were creating this training program. One of them was just a modality for self-learning. So there's a PowerPoint that's interactive. It has YouTube videos and podcasts. It's got Beachy and Bauman videos, training videos on BHC work. If you aren't familiar with Beachy and Bauman, they're definitely helpful in explaining a lot of different things when it comes to BHC work and in integrated care. So I have that, and I wanted to show you all, if I can, just kind of what I created there, and then a couple other components that were really important to us. One was shadowing, so seeing it happen in real time. We also created a checklist so that as they were shadowing, they were able to check off, hey, this is what we talked about. These were different subjects that were important as part of the training. So that was really important and helpful. And then we also had competency expectations. So we had a checklist of different skills, different things that we were expecting from them, different scores that were included in that. And we wanted to do it 90 days and then later on, but have that consistent feedback of, hey, this is where you're at. This is where we expect you to be developmentally in this position, and this is where we want you to be eventually. So we created that as well. I think some of the things that, as we're making it through this first round of interns, I think some of the things that we want to consider from here is one, just maybe even a pre-competency checklist. So having something where we're able to go, are you able to be extroverted even though you're introverted? Like, can you step out of your shell and really engage the clinic in the ways that we feel like is needed, is necessary for this work? So we're considering that. Another thing is teaching how to write good notes, and that's something that admittedly I'm not awesome at, can always improve, but is something that, you know, we want to teach our BHCs to do well, so that when a provider is looking through notes, they're able to find the information that they need and find it quickly.
Do you
And so
mind if I add something to that?
yeah, go for it.
So I'll put it in the chat, but I was just talking with one of my interns, who I'll call her out, Carrie, hi, earlier this morning. Is almost everybody has their camera off. So give me like a thumbs down if not. I'm hoping most people are familiar with like a SOAP note, if that's at least a general familiar term: subjective, objective, assessment, and plan. So for the thank you all. So for the PCBH model, one thing that is often recommended is like SOAP, but it's APSO. Because when we think about ourselves as consultants, and this is again one of the ways that we differ in an integrated care environment versus a more traditional therapy environment, our notes are written to communicate back to the provider, most importantly, right? They've sent that person to us. Thank you, Teja. So we want to put the assessment and the plan first, because they're busy. I don't want to say they don't want to read our notes, but the pieces that we have to keep for ourselves, like subjective and subjective stuff to make sure we're tracking the case well enough, may not be the most important piece for the medical provider to get back, right? They want to know, is there a diagnosis, or what is the diagnosis, and what's your plan? And part of that is when you're saying patient will follow up with PCP for med consultation, if that's right at the beginning of the note, that helps the provider know their role in, you know, hopefully you have time to go back and chat with them, but the note then serves as a reminder. So they're not digging through subjective, objective, assessment, plan, trying to figure out what they do next. So that APSO can be something that's common in PCBH.
So let me see if I can share my screen. I'm going to try this out. All right, is everyone able to see that? All right, so this is what I created as far as a self-learning training. So hopefully this works out. Let's see. So it just kind of goes through, again, the why. I think it's really, really, really important to start out with that. And then throughout, there's different explanations of what we can see, what we can do. Explaining what, here, I'll show you back here. So this was kind of what I came up with for Burl integration. Again, there's the big overall arching why, but then coming back to what is our purpose, what is our why as our individual organization on our team. So but throughout there's videos that you can watch, there's podcasts that you can click on and listen to. All of these are clickable articles. So I was really proud of what came out of this. I'm excited to show this because I think it was a really helpful way to package the information and show people, show new BHCs that, hey, we're excited you're here, and we want to offer you a really well-rounded training package to get you ready for this work. So the one thing though that I think, as I was going through this and thinking about what I had started out with and what we used and what we didn't use, one of the things that I think would be good for consideration is, as they're going through this, talking with, if you're a supervisor, talking with the BHCs about their reactions to each of these different videos, reactions to different articles, podcasts that are brought up throughout, to go, hey, you know, is this something that you feel like you can do? Is this something that you feel like you might do differently? What are your reactions from that? And I had created something. We didn't really stick with it because it's just, when we're starting something new, it's just so chaotic. I'm sure you all know that. And so it was hard to include everything that we came up with, but that's something I think in the future I would want a little bit more included in this training package. So
well, that's a really fundamental piece of general reflective supervision, Micah, right? Like us engaging and asking students to even self-reflect, or trainees to self-reflect, or interns, whatever level of, you know, training just keeps coming up, wherever the person is in their journey to becoming a fully competent, comfortable, effective, efficient, ethical BHC, that we want them to reflect on their own experience versus it purely being didactic. And, you know, I do want to note integrated care. I'm sure most of you, this has been around a lot longer than the recent few decades of like it being a really hot item. And so it's definitely been an intergenerational journey, like where we have the old school, like individuals who started this way back when Kaiser Permanente in 1950s really kind of made the first effort, so to speak. So part of what I love about Micah's presentation is just a person that knows how to use Canva versus PowerPoint, because I think it's so much more interactive and so much more helpful. So I'll give you that feedback now in terms of how much I appreciate it.
thank you. Yeah, drop a like in the chat if you're cool with Canva. Like, Canva is awesome. I love it. And it was so helpful to make something that, you know, we could be proud of, and that also that we could show that, hey, we're proud you're here. We're excited you're here. That's something that, you know, I knew that from my supervisors. My supervisors made it very clear that they were excited that I was here, but I wanted to communicate that in other ways too, on top of that, to say, hey, you know, we're excited that you're interested in BHC work, and we want you to do the best that you can in this field. And yeah, so I think to close off the training side of things, I would just say, you know, consider the why, consider your why. If you don't consider it, you can't expect people to do what you're hoping for them to do. I would say, as we're thinking of competencies, like think broader than being able to see the amount of people that you want them to see. Think broader as far as how good of clinicians they are, the skills that you want them to have, the soft skills that we were talking about earlier. And think about it in terms of, what was it like for you to enter this field? What did you feel like you were missing? That's what really drove me to create this. Was there were certain things that I felt like I was missing when I first started, and that's not anybody's fault or any problems, but it's we're always improving, we're always getting better. And so if we think about what were those things that I wish I would have known from the beginning, that's really going to help us to create some pretty awesome training programs. So like we said earlier, we really want this to be interactive. If there's things that have worked for you guys, please drop it in the chat. Talk about it. Let's share some ideas with one another. If there's things that didn't work for you guys, share it with us. And if you have any questions about some of the things that we did, we're not perfect. We're not the experts in this in creating training programs. This is something we created this year. So we have lots to learn and lots to improve on. And so if there's anything that you all have that would really help us in that process, we'd love to hear it too. So with that, I think I'm gonna, we'll give a little bit of time for the chat, but then also yeah, Paul, go ahead.
Hey, everybody. I think one thing that I do with my trainees is that, to grasp this idea of integrated care, I think we do a very good job in psychology at this point in time of educating people and trainees about what integrated care is and what it's supposed to look like. But one of the things that I've always emphasized is that when they start a rotation with me is that they shadow everybody else in clinic too. So they spend a day hanging out with a primary care physician and they hang out with the nurses and they do that stuff, because I think for integrated care to really work, everybody has to have a working concept of what everybody else's job is. And I know for a lot of my trainees, that's a new experience because they've kind of all gone through the traditional mental health model and all they've ever done is work with other mental health professionals in mental health clinics. And so, so I think that's always been very valuable. It was when I was a trainee, I did that. And so I've always pushed that on my own trainees to hang out with the people who are not mental health professionals and learn how they think and how they act, because then you'll be a more effective psychologist in an integrated setting.
Dr. Corti, I love to hear that from you, and I appreciate that perspective because I think you're spot on that we don't necessarily know what a day looks like for everybody else. And sometimes that shadowing, it builds relationships. And I think it also builds empathy in a way that allows us to appreciate one another's skills and understand. Like sometimes I think it can be very easy to be judgmental, let's say, about what we overhear from other providers or what we would like to see from them but don't get from them. And so kind of having a day in the life or even a couple days in the life and understanding, maybe for a nurse that it's not fun to be poking children all day with me, like that it impacts them, and that sometimes it feels stressful that they're being pushed off and screamed at and cried at all day long. Like that's a form of day-to-day stress. Or thinking about primary care versus, let's say, health psychology. These are individuals where it's very easy, I think, to judge and say, how do they not know that bipolar disorder is cyclical, for instance? I'm taking some recent examples of discussions with providers. And it's like, well, if you go through their day, they have to be able to diagnose everything from a rash to heart disease. Like they have to know a little bit about everything, right? And so it can really kind of help you broaden your perspective as to why or how they're not experts in the same areas that you are, and how do you fill in those gaps and support them as a team.
Yeah, we talk about curiosity when it comes to meeting with patients, like having curiosity, and that really helps us to understand the concerns better. And I think that's a great point, that we need to have curiosity when it comes to the entire clinic. I luckily am able to my desk is right next to the front desk. And so I get to hear all the phone calls and all the things and all the stress. And I make it a point to go talk to the MAs and nurses and everyone else too. But yeah, it is super important that that's built into everything too, is that we make sure that new BHCs trainees are going and spending time and having curiosity about processes and different stress that comes along with running a clinic.
And there's a lot to learn just by hearing and overhearing those visits and having those moments where you can jump in and maybe not during the first day you're shadowing, but circle back around with that person and say, hey, here's A, B, and C that I could do to support you with this patient's care, right? So it allows for that co-education, so to speak, which is hard to do as in like when you're brand new at this, it takes some courage and confidence to get to that point, to value yourself as an equal team member, right? It's gets kind of into the, maybe biomedical providers, so to speak, get a little bit more status in our culture. So that can be hard to do, to trust that you have a lot to offer, but we have immense amounts to offer. So I'm going to shift gears just a little bit for a moment. One of the things that Micah mentioned, or and showed on the training video, was the idea of a competency checklist, right? So in terms of supervision training, those of you that are working with interns, etc. In the APA, at least, I know there are multiple guilds represented here, so I assume, and it's assumption, so correct me if I'm wrong, that there are broad clinical competencies that you're sort of expected to meet within your professional guild, within your profession itself, to be considered competent, so to speak. So in APA, just some of those would be supervision and use of supervision, research, and that's going to mean different. Research is going to be different if you're at a research-based PhD program versus if you're a local clinical scientist, but they're broad domains that every student, every trainee needs to show a level of competence in. And one of the things that Micah mentioned is that this is going to look different during different times, right? So for any of you that are, let's say, training interns, there are so many resources out there with respect to what does this competency, let's take interventions, what does it look like for a practicum student, and has behavioral anchors and descriptions? And then what does it look like for an intern, which is different, right? And then what would it look like for somebody who's a postdoc or who's pre-licensure, right? Immediately pre-licensure. And so part of how and why that can be so meaningful is that the competency-based supervision really, again, over the last 2 decades or so, has become the primary model of supervision or training within integrated healthcare. It doesn't mean it's the only model. Absolutely, people still train from theoretical orientations like cognitive behavioral, and at the same time, we need to at least be eclectic in the sense that if, let's say, cognitive behavioral strategies are our primary theoretical orientation, and we want to teach skills and micro skills in that area, we still need to be meeting these broad clinical competencies. And the competencies get really specific, again, to even what does this look like in a primary care environment, right? There's also competency checklists for your nurses, your primary care providers. So in some of that initial building, depending on how much time you have, in terms of shadowing, in terms of how agreeable your providers are, how much their administration is supporting the program, there are areas where they can take those kind of pre-tests, so to speak, that Micah mentioned, and sort of they can also gain some understanding about what their role and expectations might be. So I'll say one more piece about this because I feel like I'm going on a large lecture. Part of how and why these competency checklists are so helpful and important is that prior to instituting this method of evaluation, effectively, and I'm not saying supervisors were running around just willy-nilly, like, I like this person, they pass, or I don't like this person, they pass, or they act like me, so they pass. But it gives us very specific ways to give feedback, right? So that our assessments are, what's the word, quantifiable to at least to some degree, right? Does this person turn their notes back over to the referring provider within this time frame? How you can obtain actual data in order to go back and provide supervision and growth and training versus a little bit more dynamic relationship, if that makes sense. I feel like I've said a lot.
I
but
would say too, like there's probably, and again, there's probably people out here who know more, but I almost, the competencies are great, and to check in every so often on those are really great, but how quickly things change in our clinics, it may even be more important to figure out how to assess those skills on an ongoing basis. And I'm, like I said, I'm sure there's something already out there that I don't know of yet. But yes, I think, it's so important to have to be checking in on those competencies, but checking in on them pretty frequently, because things change really quick.
Well, and I think to at least, if I'm understanding your question and answer that, or comment and answer that in part, I think when we are able to accompany our trainees of whatever level into some of their sessions or into many of their sessions, and we can give, we want to be a little bit cautious about how much we correct in front of the patient. Like, we have to get a little bit comfortable with letting our students and our trainees become the BCH, right? And so, having that more immediate feedback. So if we're shadowing, they're shadowing us initially, and then we're shadowing them, those immediate opportunities for feedback. Or if we're doing a co-visit, again, asking for their reflection of how things went. Seeing if they had any specific areas where they felt particularly unsure or uncertain, and trying to address it a little bit more in the moment. Like we know with most behavioral strategies, like the more closer in proximity we can get to it, the more likely it's going to be helpful or sort of stick for that person. So I know that I'm going to address a quick thought, and then I do want to say something else about supervisors too. So let me start there, and then I'll hop back around. This is an ADHD brain for you. So one thing for the supervisors on here, okay, one thing that is interesting to me, and I think is helpful to keep in mind in terms of how we're moving forward in the field, is that we don't yet have PCBH supervisor competencies, right? And that is sort of an important thing to consider, because just because I'm a psychologist doesn't immediately make me a good administrator or boss or trainer or supervisor. There are things that I need to learn and know about those roles that maybe feel familiar to me, but aren't necessarily immediately translatable. Just like a traditionally trained psychologist coming into the clinic, it's not immediately translatable. So there are new studies and research happening where especially out of Austin, UT, Houston, I think San Antonio, maybe. There's some Delphi studies going on where they've requested people who worked in academia, teaching, and provided supervision, and also worked as a BHC. So they're considered kind of those subject matter experts. Like, what do behavioral health supervisors need to have, and can we create a competency list for them as well, right? Because we also have responsibilities to make sure that the supervision we're providing, fits the clinic that we're in. Sometimes state laws conflict with federal laws. We know this, then conflict with guild aspirations. And so it's, there's a lot left to still be done. This is not a completed area of research, so to speak. Because again, some of our supervisory skills are going to be translatable and some aren't. So I just wanted to kind of make a note of that, that there's some more research going on there. So I did get a question in the chat about addressing territorial issues among varied disciplines in terms of how do we train individuals to work in these environments where sometimes, you know, there's a lead or one person is in charge, so to speak. Does anybody want to comment on that, or anybody have some ideas to share?
That's such a great question. Somebody has to have some thoughts on that.
Well, you know, I have thoughts on it. I'm trying to be comfortable with silence. And
That is such a great question.
I think the immediate thing for me is humility. I think, you know, we, especially if we are the new party, sort of entering into an established clinic system, that approaching the team with a humble manner, that we are here to help, that our goal is to not, I'm a doctor, so I trump an MA. Like, that is not a team approach, right? So I think another piece of that is what we talked about earlier, shadowing different professions, you know, and this kind of moves into cultural competence as well. The primary care environment has its own culture. And each system is going to have a different culture too, right? Like within that system. But it is common for, like, where does the buck stop? If the primary care physician is the person who is going to be in charge of that patient's treatment, so to speak, that person may want to have a little bit more control, so to speak, or want their opinion to kind of trump other opinions, so to speak. So a lot of this is being humble, using those skills of how to read people and, like, how do I work with this person? Because even within a given discipline, you're going to have other people who are very humble and open to your ideas, and then you're going to have some people that want you to do it their way, etc. So Dr. Gillum, I noticed you turned off your camera, so I'm hoping you have something else to add.
Yeah, and I didn't really formulate my thought here before you finished speaking, so
That's
I'm gonna
okay,
kinda
I just babble along.
So I'm thinking how important it is to educate a new BHC on how to educate each team member that they work with on how they can be a benefit to them, and make sure that that language is really solidified before they go into that clinic. But I was thinking even more importantly than that, a lot of that is going to be reliant on those initial discussions that administration have with the facility that maybe we're embedding into. So at an administrative level, making sure that they fully understand the why. So play back on that. They understand how this is going to benefit the clinic so that they can trickle down that information appropriately. Because what I often see is we may train our individuals to really advocate for themselves and educate in their clinic. But if that has not been properly solidified at the top of the chain where that information is derived from, then it still flows down incorrectly, and it can really ruin the entire experience, at least for a time being. So I was just going to point out that I think that's super important when we're implementing integration in any space, that we're really at every level of stakeholder, that the information is consistent and it's supportive of everyone that works in that clinic.
That's an excellent point. And, you know, again, I think a piece of that is broadly speaking culture, right? And we know from general individual like supervision strategies and culturally informed supervision and training, if we do not bring that up as the person with the power, right? Even if we have diverse interns or individuals who are different than us in a system, like a lot of times students or trainees are not going to be the ones to bring up cultural concerns for themselves, so to speak. Like we have to bring it into the conversation. That's our responsibility. And so in some ways we take that idea and build it up to the bigger system that, you know, this is like, we have to learn this culture and we have to learn and share where we are and how we can be effective in that culture and be helpful. And I really think once you're able to like figure out how to work with a given provider in the sense that they, whether it's a front, Micah, you mentioned front desk staff, like I give them all the kudos all day long. Like every time I walk back and forth, because they're really the front line. Like they literally are the ones who get the, like, my insurance should be fine. And you were supposed, I mean, they get a lot of crumb, right? So to be able to even support them is important. So, you know, I could go on and on about this because then we have to kind of watch too. It's not uncommon in a primary care culture for, let's say, physicians to quickly treat a staff member, right? Like maybe that person has a headache and the physician will evaluate somebody that they work with. That's not uncommon at all. It's not unethical. And for us, that can sound, who are traditionally trained, that can sound a little like dual relationship, flags, red flags, red flags. And so knowing ethically that that's common can help us be ready to navigate those requests a little bit more comfortably. I think that, you know, maybe we're providing referrals or giving ideas or what have you, but to not be completely shocked in terms of feeling like that's some kind of violation or ethical concern, because it happens in primary care all the time. Because healthcare practitioners like to help each other. They like to help people.
I was going to go back to, so back to what we were talking about as far as like helping out with, I don't know, the culture, the relationships, the different things. And I think it really comes down to influence. Like you have to have influence in this position. And part of that, yeah, we have to have humility, but we also have the assertiveness to speak up when we need to say what we need to say. And that will be beneficial to the providers, the front office staff, the MAs, and ultimately the patients. And so I totally agree with everything that we've said, but I think definitely what I've seen here is having influence, showing up to staff meetings, showing up to provider meetings, showing up in these places where, you know, we can be able to be a voice for people. And you're right, Dr. Lou, there are going to be times where like today, I feel it coming. There's something happening where I'm later on today, I'm going to be, there's going to be something related to a staff member that I'm being consulted on. And it happens. And there is a fine line that we have to walk as far as ethics go, but there are going to be times where we have to be the mental health expert. And it's so important for us to step up and be the difference there and help figure out avenues, resources, all that kind of stuff for people.
Yeah, absolutely. And you know, that's part of functioning as a team, right? That's a role we can play, or that we do play. And I think it helps to not be shocked by it, to know that it's coming. As Dr. Gillum said, you know, education and training is so important. And I mean, we're just touching on, you know, like we go on and on about this, as we say with all of our roundtables. And I agree, Dr. Gillum, that we really have to believe in the model. It's just like any other sales, I don't know any of you that have had to suffer through sales jobs, like to get yourself through school or whatever that may be, that truly, truly, if you don't believe in what you're selling, it comes through. And especially if you're new, or in a new clinic system, really believing that it matters that you can have one session with a person, give them some psychoeducation, let them express themselves a little bit with a little bit more time than they have with their PCP, give the PCP a strategy that can be immensely helpful. And again, the research supports that. And even with outpatient traditional therapy, often the mean amount of sessions is one. So take what you have in that moment and use it and believe that your skill set is important. And I think we can be both humble and confident. I don't think those two are opposites. I think that they can coexist, that we can humbly present our expertise. And when somebody gives it a chance, then they're hooked. Like, I'm just thinking of, I have one of my interns here with me, Amanda, and once we got one of her family health providers was like, finally sent her a referral after however many months we had been here. And then from that point forward, it's been like 5 referrals a day. It was like, oh, that was darn helpful. So, Dr. Gillum, were you going to tell us it's about time to shut up?
I was gonna let you finish and then I'll take it away. Do you guys think that's a good place to end? Any last comments?
I'm gonna literally check Micah, and I had some emails this morning. I was not emailing while driving. I want to be very clear. Yeah, I think maybe I wanted to make a nod to telehealth supervision, but I'll just make that nod that, being cautious of some guilds, again, are, when you supervise, are going to want you to show competence in telehealth supervision specifically. So I mentioned earlier that there's not always necessarily competencies in place for what makes a BH supervisor, but if you're using telehealth modality, research shows that students tend to find that just as effective overall, and it can reduce costs through travel, get us into different areas. However, to be a supervisor, you do need to have some training specifically in telehealth. So I'm just going to nod to that, and I'm sure we've done a roundtable on telehealth. So.
Thank you both so much for being here and sharing. In closing comments, I want to say January 7th, there's going to be a webinar, The Minds, Lives, and Motivations of Mass Attackers. It's a 3-hour category A credit. February 1st, we'll have our next roundtable, which is in models of integrated healthcare. That will also be for category A credit. And February 17th, gender affirming mental health care, which is awesome. 2 hours, category A. Hope to see you there. Thank you all for being here.
Good to see everyone. See you next time. Great job, Micah. Glad to work with you, bud. See you next time.